should not only be able to recognize, diagnose, but fully treat and manage, for the most part, on your own. So that is where, so not a whole lot of picking, refer to specialists for some of that. That's block 3. So we'll talk a lot about that in block 3. But I need you to think block 2 is most of what I'm responsible for. So bread and butter pediatrics. So this is, if you're going to work in a Peds clinic, if you're going to work in an urgent care, an ER, any of those things, this is what you're going to see day in and day out. That's just the way I need you to think about block 2. So first thing up for block 2, we have a whole lecture on fever. An entire 2 hours dedicated to fever. And why, you ask, why are we doing a whole lecture on fever? Well, it's got a whole subsection of the Peds. There's an entire subsection of your certifying exam that just deals with fever. So on this next exam, there's going to be a lot of, this kid has a fever and a rash. Now how do you distinguish that? Your patients are going to come in, fever, 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 fever. So how do you pick apart what that differential is going to be? So that's why it's got its whole lecture today. So we are going to leave febrile seizures for the neuro lecture. However, we're going to talk about all things to do with fever over the next 2 hours. Okay, so when we're really talking about a fever, we have to start from the beginning. So when we're talking about what a normal temperature is, that's one of those things that most people know. We typically use it obviously in the Fahrenheit, but really what we need to think about it is in degrees Celsius, because when we're talking about what a fever is, we're saying that the average temperature, which humans live at, 37 degrees centigrade, a fever is when that moves 1 degree centigrade higher. So a fever is 38 degrees centigrade, 1 degree higher. And why does that matter? Because 1 degree centigrade is high enough that it can denature a protein. So if you ever wondered, when people come in and they say, well, I'm at 100 degrees, I have a low-grade fever, for the rest of your life, that's not a thing. Low-grade fevers, you are either high enough to denature a protein, or you're not. There ain't nothing in the middle, right? So if you're thinking, I'm low-grade pregnant, that's not a thing. It's very similar. Are you high enough to denature a protein, or are you not? So I hope that I can convince you to get on board that low-grade fever, not a thing. You're going to hear it for the rest of your career from other providers, from lay people, not a thing. Now, why do we have a range? Well, the way they, you guys know me in my medical history nerding out, when they figured out what normal is for humans, they literally took 25,000 people's different temperature and said, on a day where they were not saying they're sick, it was from this to this. So we have just said that it is an average of 38 degrees centigrade. Most accurate is meaning it is the core temperature. So if I could take everyone's temperature from right behind their belly button inside their gut, I would. So the closest approximation to a true core temperature is going to be that rectal temperature. So if you're thinking, how do I get a most accurate one from a baby? Rectal temperature. So anything closest to the core and out is going to be what you are looking for. The rest of the time, we're going to say that people have an elevated temperature or they're hyperthermic, totally fine. But when we are saying provider to provider, somebody has a fever, we are saying their core temperature has risen enough to denature a protein. That's what we mean. Rarely are you going to see a body temperature internally rise to a lethal level. So you're going to see patients for the rest of your career, and people are going to bring their child in, particularly because they're going to have a really high fever. Nobody knows what high means. There's some studies that even providers are thinking, oh, once we get to 103, 104, fever's a fever, right? So it doesn't matter how high, how low. The big takeaway is that internally, your hypothalamus is not going to just spike and send you into 108, 109, 110. It's not going to do that. So you're really not going to have a fever in a neurologically normal child that is intact who's going to rise above those lethal levels. That is different than if you have an external heat source. So external heat sources, we're doing 2-a-days in July in San Antonio for football practice. That's an exogenous heat source that's coming in that is not internal. Okay, so a fever is not going to go high enough to denature your brain like that. An external source and heat stroke will. So two different patterns there. Your diurnal pattern, so the same thing when we talked about for block 1 with colic. right? For whatever reason in the evenings, seems to be a pattern, very similar with your core body temperature. So it's going to be lower in the mornings, higher in the late afternoons and evenings. So another thing in pediatrics, right? You're doing fine all day, you get home from work, and now these kiddos are crying and have higher temperatures. And this is a recipe, and you can see why the evenings in the ER or urgent care always tends to be a little more fuller based on physiologic patterns. So anytime in pediatrics you are thinking you are seeing a child, a third of all visits, oh, session has moved. Why did it move? Is the temperature? Oh, I thought it was because I moved. I'm sorry. I'll stay over here. A third of all visits in general are going to be something, a fever plus something, or a fever on its own. So you're pretty good guess that 1 out of 3 patients you're going to see in pediatrics has something to do with a fever. Particularly if you're under the age of 3 years old. So if you're under 3, I'm just going to stand over here. I'm just going to start walking. If you're under 3, a lot of times this is the first time that you are seeing whatever virus, bacteria, inflammatory marker, whatever it is, and so your body as a small child is reacting to absolutely everything. So with that first time you're seeing things, struggling today, struggle busting, you're going to spike a fever. So why you see it more commonly in under 3 and younger. Also, you have a very, very robust immune system that really hasn't started to regulate things yet. So if you or I had a fever of 103 or 104, I'd be like, you should go see someone right now. Your body is mounting an exaggerated response. You are quite sick. A kid has a fever of 103 or 104. I say, well, that's just a day that ends in Y. Congratulations, you have a child with a normal functioning immune system. Totally normal. Okay? You see that kind of dive at the age of 3. Number 1, you've had a couple of years to regulate that system. Number 2, you've had a lot of exposure to the common different pathogens. So you're not spiking such an inflammatory and immune system every single time. When we talk about fever in general, pros and cons. So this is really putting provider brains on when you're thinking about, it's not just a vital sign, but it's got things that you need to consider about this. So what are the pros? Why do we even mount a fever? Well, we said it's to denature proteins. So it's going to kill off things that shouldn't be there. It's going to slow down viral replication in cells that are trying to replicate viruses. And it's going to draw the inflammatory system in your immune system to bring resources. That makes sense. So fevers are really good things. They are pro in general. What about the cons though? Why is everyone so worried about this, and why do especially parents not want to have fevers? Well, the other thing when we're thinking about physiology is it takes a lot of cardiac and oxygen to be able to keep that high of a temperature. So you are going to have a significantly higher cardiac output. You're going to have a higher minute volume for how much you are breathing, and it takes a lot of energy metabolically to continue to function at that higher kind of on-go speed. Well, that's fine if you're a normal child. If you have cardiac complications, so if you have congenital heart disease, we'll talk more about that block 3. If you have pulmonary disease, just at baseline, so you're premature, or you have asthma, anything where you have something there, or if you have an inborn error of metabolism, those things are going to make it really, really hard on this child's body, and so a fever can actually cause some problems. So as a provider, there really are situations where you're like, let the fever fly. It's going to help bring immune responses. Other times where you're going to say, that's really going to hurt the cardiac output of this child with cardiac congenital heart disease, so I need to take care of the fever so that I'm not putting them at an increased cardiac risk. The other thing when we talk about febrile seizures, anytime where there is an elevated temperature like that, your seizure threshold is much lower. So you are much more likely to have a seizure if you are having a fever. So if you have epilepsy, that could be another situation where you would truly want to be treating the fever to lower the risk of having some of these secondary complications. It's not always infection, so a reminder that fever is not just your infectious cause. There's all the different inflammatory reactions. So last block, we said Kawasaki. Did we talk about that, or is in that block 3? We didn't talk about Kawasaki's yet. I've made this up in my mind. I have already gotten to block 3. When we get to block 3 and we talk about Kawasaki, that is a vasculitis that is an inflammatory vasculitis. So you have pathologic entities that have nothing to do with a virus or a bacteria or a fungi that are inflammatory in nature. Neoplastic, have you guys started chemo yet?
Negative.
Okay, well, I just made up that you guys are getting all this info yet. But from a hematologic complication, this would be one of the indications that your body is making aberrant cells as well. So from a neoplastic. And then there's this big miscellaneous. So fevers come in these weird packages. So if you have a fever that you truly cannot explain, that's when you start looking at box 4. Is this one of the zebra type diagnoses? So we won't touch that as much. It's a little bit more in infectious disease, but we will hit on that just a little bit. When you're thinking though, what is the most common? You're looking at infectious, especially for kids. So if you're having to guess for block 2, you're thinking they have a fever, it's probably infectious. If you had to guess, okay? It's just the most common. Pick a virus, any virus, pick an infection, any place. So common things being common, we will go through all of those. When you look at a viral infection, a fever pattern looks very different than bacterial. The way I talk to parents about that is with the hand. So the hand pattern is what I usually will give them. To say a viral fever typically goes like this. Day 1 is your thumb. You question to yourself, you're like, are you getting sick? Is this a fever? I don't really know. They might be in that kind of 37.3, 99 range. Day 2, they get a fever. You know that they're sick. It stays. Day 2, 3, 4. Where do you think most parents start to say, I need to go see somebody?
3.
Day 3, exactly. So they make an appointment, they come see you on day 3 when it is the highest, and then you look like a magician when they look like they have a viral pattern, because it's going to stay high on day 4 and then it's going to drop off day 5. So that's the typical viral pattern of a fever that you're going to see in really any adults or any humans, but particularly in children. And when you start growing extra fingers, and when it doesn't follow that pattern, that's when you need to start expanding your differential, or is something else going on. So it's the typical viral pattern that you see of fever. So slowly up and then kind of declines over those next few days. Contrast that with bacterial fevers. Those are typically higher fevers very quickly. So instead of following the hand, it just shoots straight up and it will stay there until appropriately treated. And once appropriately addressed at the root, once the right antibiotic choice is on board, it typically drops off very quickly in the next 24 to 48 hours. Hyperthermia, the typical pattern of that is for children under the age of 3, but really in those kind of standard deviation of that, 2 months to 5 years, you see this exaggerated pattern where they get very, very high fevers. This is what I was alluding to earlier. When's the last time somebody in here had a fever of 103 or 104? Probably in a room of 70 people, it's been a while, right? If you have kids and you said, when's the last time that your kid had a fever of 103 or 104? You're like,
Last weekend.
Last week, 2 weeks, last month, the last time they were sick. Right? So, pretty exaggerated response there. Can be an incidental findings. You see this, we kind of talked about that in block 1 with Nelia rubra. So people that are thinking, oh, my baby is just really cold all the time. They see them in July in San Antonio, bring the baby in with 3 onesies and 2 blankets on, and so their temperature is 102, not a true fever. You can see weather-related things. That typical presentation, kids, it's going to be exaggerated. So those are the kids when you see flushed cheeks. You see flushed cheeks in a question stem, they're trying to tell you that there is a fever or there's something else that's going on there. The shivering and the fatigue, it makes sense. There should be fatigue. Their systems are on go mode. Their cardiac output, their minute volume, all of those things are at a much higher rate. Makes sense that they are going to be fatigued from that. Irritable. We're going to talk about that word here in a little bit. Forever will mean something different for you as a provider. And then you should see vital sign changes, obviously tachycardia and tachypnea. So in forever, from now on, you can't ignore those vital signs. if you see a child with tachycardia and tachypnea or, you have to have an explanation. Maybe it's because they're screaming, maybe they're crying, maybe they're running around the room. It's a totally fine explanation. But if you have a child that has tachycardia or tachypnea and you don't know why, you need to go looking for it. What's their level of alertness? If you have a child that is laying there with eyes that say, help me, compared to the child who's febrile, who's running around the room, which are you more concerned about? The floppy child who's laying there saying, please help me. How are they positioned and moving? When a kid or when a human has a fever, how do you feel? Not great, right? So if you're just laying around and feeling real, right? It tells you how the child's feeling. Level of playfulness. Kids are amazing, so they'll just be running around the room. The parents are very concerned about their fever of 102, and they are zooming like dog zoomies, but kid zoomies, where they are running around, and you're like, they're just fine. Right? They're gonna make it. Got the zoomies. Irritable but versus fussy but consolable. So there's going to be some words that forever from now on you're going to use differently as a provider than you will as a lay person. So the first one of those is going to be irritable, right? When you think irritable, what do you think as a quote-unquote lay person?
Easy to anger.
Easy to anger. What else?
Impatient.
Yeah, impatient, right? So a lot of parents will come in and say, my child is irritable, right? And you would think what they're meaning is they weren't happy that we didn't have blueberries for breakfast, right? They're irritable, they're not wanting to play, they're wanting more comfort sometimes. That's what parents are meaning most of the time. When I'm telling you, provider to provider, somebody is irritable, I'm saying their meninges are inflamed, and I'm really worried that they have meningitis. They're irritable. Irritable meninges. So if you go tell another provider, this kid in room 7 is irritable, I'm going to ask you, do we need to do an LP? Because that's what I'm thinking you're telling me. Otherwise, if you're going to say they're grumpy, they're fussy, they're something like that, but irritable is going to mean, I think they have meningitis. So if I put irritable on a, not in quotes, in a test question, I'm trying to tell you that. What else? We're going to use the next one. The other one, I'll just say it right now, is lethargic. Parent comes in. What does lethargic mean to a parent?
Sleepy, tired.
Sleepy, tired, not their usual playful self. That's what families are meaning when they're saying lethargic. Provider to provider, I'm saying that child is obtunded. The child is not wanting to wake up. That child does not have a normal level of consciousness. It is truly lethargic. I'm looking at a different GCS score. Okay? So use the correct words. Words are going to matter between the way that you write things legally and the way you're communicating provider to provider. So you can have a conversation all day long with moms and dads that are saying, yep, they're irritable, they're lethargic. If you turn around and write that, you have communicated to another provider, I think they have meningitis and they were obtunded and then I just sent them home with Tylenol. Right? Not a safe thing to do for your own license. So, for you guys, are you concerned or not concerned if a child is sitting there and they're just glassy-eyed?
Concerned.
Yeah, more concerned. Are you, they're staring vacantly into space? Concerned or less concerned?
Not concerned.
I'm more concerned.
Oh.
Something's not right. They're sitting on an exam table upright and cooperative. I had one cohort, they were like, if that was my child, they have ADHD, I would be very concerned. So, yes, but if you get a description like that, I'm concerned. Reaching for objects. Not concerned. Cries when examined. Depends on the age. I'm not concerned about that. That makes sense that a new human that's touching them, not happy about that. Cries when held by parents.
Concerned.
Yep, more concerned. That's not normal. Remains still with lab draws and IV attempts.
That's concerning.
Super concerned, right? Lab draws and IVs, you should feel like there's an octopus that has 17 legs that's trying to come out from the beyond, right? These kids, if they're laying there and like they look at you like, help me, with these glassy eyes, very concerned. Perfect. When you're taking a history, there are other things to consider. So For the onset, when you say, when did this fever start? What you're really asking is, when did the consecutive days start? So it kind of goes with how long does it come and go. So it's very different pattern if I say, when did the fever start? And they say last Tuesday, and I'm thinking Tuesday, Wednesday, Thursday, Friday, Saturday, Sunday, Monday, Tuesday. Wow, we've had 10 days of fever. Then if they said, I had a fever Tuesday, then nothing, and now it's Tuesday again and I have a new fever. So really getting a history of how long is going to make a big difference in your workup. When did it start? How long? What was happening before it? You'd be shocked the amount of time that people won't give a history that will say, I had vaccines 2 days ago, or I was around somebody who was sick a couple of days ago. So what was preceding the event? What kind of underlying medical conditions? Who have they been around? Some of those normal questions. The other thing is down in S, how did they take it? So I had one, it happened to a colleague of mine, we were in the same clinic. And they said, how did you take the temperature? And the family said, yes, we did. I said, what was it? And they said, 350 degrees. And we were like, 350 degrees? How did you take this? And they said, well, we didn't really have a thermometer at home, so we turned the oven on and we put the baby, and when it matched, that's how we determined how hot the baby was. So sometimes you really have to ask, how did you check to see if there's a fever, right? Did you just do the back of a hand and say that felt pretty hot? Did you put them up next to the oven? Did you take a oral temperature, rectal temperature? How did you obtain said temperature? It will matter. And then a lot of times you'll say, what did you do to treat at home? Are they dosing appropriately? We'll talk about the dosing. For what medications are those appropriate medications? Have they not tried anything? So, and then has it happened before? So is this something where they've been medicating for days on end? Have they been doing this for 3 weeks and they've actually had a fever every day and they've been giving Tylenol and Motrin to mask this? Or is this a true, it's popped up out of nowhere? So the history on a fever in a child will really determine which way you are going to go. History is everything here. If you're under 2 months of age, this should be a throwback from block 1. If you were under 2 months of age, last block we were talking about 1 month and younger, but really under 2 months, you need to be thinking, this is neonatal sepsis. I'm really worried about this. Do not stop, go. Do not collect $200. They need to go to the emergency room for a full workup. So under 2 months, if you see anything in a test question, the child is 3 weeks old, the child is 6 weeks old, the child had their 2 week well, and the next day they had a fever, do not pass go, do not give them anything else, go to the ER. That is the answer, every single time. If they're over 2 months, so we know what we're doing for under 2 months, they're going to go get a full workup, and we're going to talk about what that full workup looks like, so it's going to be a review from block 1. But if they're higher than that, it's really is it a pro or con? So does this child have, what were some of those things that were the cons?
Heart condition.
Yep, asthma. So what system was that? Pulmonary, cardiac, metabolic, one more. Seizures, right? So those things. Do they have any of those reasons why I would need to be more aggressive or less aggressive? So what is my situation here? As a reminder, you'll see this over and over in your careers. People will treat fever. They will literally give an antipyretic and then think they have treated the source of whatever it is. That is not it. You are treating that symptom or that sign, but you are not treating the underlying etiology. So just as a reminder about that. However, if you've been febrile, it's pretty uncomfortable. So you can imagine that children especially, especially those younger ones, they can't communicate how bad they feel. So they're not going to want to eat or drink or do any of the normal good things if they feel really bad. So sometimes just treating the sign can be very helpful, so that you can help them get better on their own. Meaning, most of the time, keeping them hydrated. So that's usually the big spiral that kids will go down. They will end up febrile, they will then not drink, and now they are in a spiral where they are dehydrated and febrile, so they're losing more and more fluids, and that's when you get into a situation where they get pretty sick. So, pushing fluids is going to be a big thing. These two, some of the feedback when I first got here from phase 2 said, wow, I really wish that we had known the Tylenol and Motrin dosing before I got to phase 2 because I use that every day, all day in pediatrics. So if your question is, do I need to know these dosing? The answer is going to be yes. So just go ahead and star highlight, underline this slide. The 2 options, specifically for kids, 2 months or older. So remember, if you see a child that I put in a test question where they are 6 weeks old, don't give it to them. But 2 months or older, they can have acetaminophen. Your dose, 10 to 15 mg per kilogram per dose. It's going to be every 4 to 6 hours. Why the range, and how do you know what you're going to pick? For kids, do you typically go on the lower side or the higher side?
Lower?
Ooh, this is good. Which one?
Lower?
Lower? Okay. Why lower? You can always add more. Okay. Why higher? Yes. Typically, I will say, if I am dosing, I will go on the higher side. If you guys have ever tried to give medication to a baby, the amount that will get spit back at you is incredible. So if you are on the lower side of the dosing, and they spit half of it back in your face, you have now just underdosed them. So I will usually go, as you are totally fine to do 10 mg per kg, totally within the range. As a provider, this is just Dr. Clint, I usually go to the 15 side, just knowing that they're probably going to spit some out or not swallow all of it. 6 months or older, that's when we can start to add ibuprofen. So be careful on that. If I give you a 2-month-old and they have fever, don't pick ibuprofen. Don't pick that because they're still too young. Their kidneys are not old enough to be able and mature enough to be able to process that appropriately. That dose is going to be 5 to 10 mg per kg. So I will usually dose at that 10 mg per kg. And then a little bit longer dosing every 6 to 8 hours. Your textbook says to pick one and stick with one and to not alternate. That is a personal preference for your practice. Some families, if they're alternating, they are going to forget who gave what when, and so it's better to stick with one. Some prefer to alternate. As long as you know how you practice and what the family, and they have clear education of what they're going to do it either way, but your textbook says to stick with one and use the second one as needed. Other things to do. If you bring a child to the hospital for a fever, most of the time, then families can do the things at home that we're going to be doing for them in the care setting. So they are going to get cool baths or cooling blankets or ice packs in their axilla or in the groin region or in the neck region. A lot of times education can go pretty far, especially for the older kids, that a lot of times they really don't need to come into a care setting, that they can be managed at home appropriately with correct dosing of Tylenol, Motrin, and cooling techniques. So how are we categorizing this? So we've said, well, what is fever, who, and what, all these different ages. So fever is going to fall into a couple of categories, and these definitions will matter. So fever is short duration, means they are coming in, they have signs and symptoms, they have a fever, and I can identify the source. So on a history and physical examination, parents come in and say they have 102, they're 39 degrees, and I look in the air and there's a raging otitis. I know exactly what this is from. So that's going to be the fever of short duration. The majority of the time with kids, that's what we're talking about. Then you have fever without a focus. So this happens a lot in kids where they will come in, they have a fever, you'll look them up and down, history and physical exam, you can't find it. Their lungs are clear. They don't have anything in their throat. There's nothing behind the ear. They have no rash. You have no idea why they have a fever. Do you treat those people with antibiotics?
No.
For the love of God, do not do that. If you don't know what you're treating, stop. Stop it. Right now. From a pediatrician to fellow providers, do not just treat that. Don't make up that you see an ear infection. Don't do that, because that is going to mess up some of the stuff we'll talk about later. It's okay to say, let's just come back. Let's go do a repeat physical exam tomorrow or in 2 days. Because over time, we're going to see they'll either get better or they'll get worse. I know that sounds really stupid, but it's true, is that fever will declare itself over time. And that is going to be much better than giving a kid a medication that they might have side effects for which you don't even know what you're treating. Okay? So that's going to be fever without a focus. Then fever of unknown origin is when you hit the magic 8-day mark. So some sources vary. You'll hear that it's 7 days and 12 days and 14 days and 10 days, all over the place. Your textbook goes with 8, so we're going to go with 8. More than 8 days of fever where you can't find a source, now you are in fever of unknown origin, and it's a little bit of a different workup that we're going to do at that point. So know your days for that, for this second test. Okay, so when you have those younger kids, and you're looking to say, what am I classifying this as? That 0 to 28, those neonatal fevers, we've already said don't pass go, we go straight to get care. And the second part of that is that it's any reported fever. So this does not have to be a confirmed fever. If a parent says they had fever, they need to be evaluated. So don't, on a test, don't pick. The parent said this and you need to have them go by a thermometer and confirm the temperature before they seek care. Don't pick that option. Just tell me right now. Then there's a category, once they're outside of that neonatal range, from basically 1 month to 3 months, they're at a medium risk. And then the children that are a little bit older. Once they're past that 3-month mark, their risk stratification goes down. If they at any point look toxic, meaning they are truly irritable, they are obtunded, they are lethargic, they are in a way that they are a sick-looking child, it is okay to do a prompt evaluation and empirically treat. That is not the child that you're going to say, oh, we'll just come back tomorrow, we'll keep looking for a history and physical. If they are toxic, go ahead and treat them. And just as a isolated thing, again, things you'll hear on the outside is people will say, oh, this is just a fever from teething. Studies will show that really you shouldn't get a true fever from teething. You'll get a inflammatory response, so it will be an elevated temperature, but you really shouldn't have a true fever. So just a side note, most of the time, a virus from whatever it is that they put in their mouth that is concurrently at the same time. Okay, that's 0 to 3 months. What's your most likely etiology? Infectious. Inside that common infectious etiology, it's going to be, your first one is going to be a virus. Second is going to be a virus. Third is going to be a virus. Fourth is a virus. Fifth is a virus. Down to like 100, right? If you have to guess, it's going to be a virus. So go ahead and just pick a virus for those younger kids. Pick one, any one, and over the course of time, so clinically, that's going to be what a lot of what phase 2 is for, is you will be able to pick out different viruses, right? Already with the way that it is going, if I said that you had a seal-like barking cough, what are you already thinking? Croup, right? You've learned those terminology, and croup is caused by what virus? Oh, come on. Paracroupers? Para-influenza virus? Yeah, the paracroupers instead of the paratroopers. But, right? So you'll learn to be like, oh, that's croup down the hall. You'll hear the RSV cough. The RSV cough has a specific sounding cough, and you'll be down the hall and you'll be like, that kid has RSV. You will be able to say, you'll see kids that will come in and they'll have red eyes plus a cough and a fever, and you're like, that's adenovirus. Over time, you'll be able to pick out which virus is which. But if you're just having to pick what's the most likely etiology, most of the time it's going to be virus. The next most common, if you have this age group, is going to be a serious bacterial infection, an SBI. I don't love that acronym, but whatever, we use it. So if you're thinking, what is most likely to be infected? It's somewhere where there's a fluid inside this child's body. So that should make sense. Where you're having a UTI, there's fluid there. Bacteremia in the blood, there's fluid there. And meningitis, there's spinal fluid there. So anywhere where you're going to have fluid is going to be where you're going to see these serious bacterial infections. E. coli being the most common, because UTIs are going to be the most common of those. E. coli is going to be the most common of that. Other ones down the list, so pick anything. Anything can get infected, right? If you haven't learned that from IPAP at this point, anything can get infected. It's just memorizing what's most likely of the different ages. In this age group as well, if you're thinking what's going to kill them, right? RSV, probably not going to kill them. Rhinovirus, probably not going to kill them. Adenovirus, probably not going to kill them. HSV will kill them. So herpes is the one, do not miss that one. That's the one virus that in this age group is probably going to kill them if undiagnosed. So herpes under that 28 days old, so really making sure, did I check the birth records? Did mom have any open lesions? Have I sent a test for this? Is the child sick? and I think it could in any way be herpes, then what am I going to try? What am I going to treat with for that? Acyclovir every time, right? So that should just roll off your tongue. What, under 28 days, could it be herpes? Start acyclovir. So we'll just put those together. Yes, sir.
I was just curious, is that specifically HSV2 then, not 1?
It can be either one. It can be HSV 1 or 2. Okay. Usually 2 is worse, but if you have 1 and it does go into the meninges, it can be a pretty devastating outcome too.
Correct.
Big things to know. So the common things, if I had to pick this is just risk stratification, and this matters when you're picking empiric antibiotics. So if you're thinking, what should I start for this toxic looking child in front of me? It's based on the epidemiology of that. So the most common things, we've said E. coli. They're brand new born as well, and I'm thinking, what could be in the blood? Well, GBS, group B strep from mom could be the most common. Then down, I'm going to think Klebsiella, Enterococcus, and the list goes. The biggest thing to take away from that is E. coli is your most common. So that's why all empiric treatment needs to make sure that it's covering for E. coli. Is that a gram positive or a gram negative? Negative. So I need to have some sort of gram negative coverage there. The other things, when I'm looking at what do Klebsiella, Neisseria, and Streptococcus have in common? Aspiration could be part of that, yep. What about their bacterial structure is the same for that? And Neisseria, is that one in there? Yeah, Neisseria is the fourth one. What's that called? You're correct. What's that called? Yes, it's encapsulated. It is encapsulated. So all of those 4 particularly, so pretty common things, they're encapsulated bacteria. So I not only need to cover for gram negative, I need to cover something that's going to take care of a lot of encapsulated organisms. So that's why knowing those common epidemiologic things is going to matter, because that's how you determine what you're going to start for these kids. Okay, we already said the clinical manifestations, so we got that. Quick review. They're fussy, potentially irritable, potentially lethargic, fatigued, and then that is what they're going to look like. So we already said tachypnic, tachycardic, flushed on exam, things else that you might see. The other one that I wanted to point out for this, where is that one? Oh yes, the skin. So petechiae. If you see petechiae on a child who is febrile, worried or not worried?
Worried.
Very worried. What are you worried about?
Hemolysis?
Your faces look very worried.
Hemolysis?
Not quite that. What pathogen are you worried about?
Like
Neisseria, yes, you were worried about Neisseria. I don't know who said it, but yay, way to go. Neisseria, you are worried to death that they have a Neisseria meningitis and they are very, very, very sick. So that's the other one. That would be a no-miss one. If they have one specific joint and you see something focal on exam, that's going to be an area of concern too. So this would be your petechiae. This child, you should know at this point that this child looks really sick. So if there are questions about that, dear God, please come and find me. Let's talk about that. This child, very, very, very sick. The bottom right is actually another example of petechiae that have coalesced. So they have so much petechiae that it ends up looking like a giant hematoma, but it's really coalesced petechiae. And even kind of the purpura has kind of coalesced there. So, that neonatal sepsis workup. They get to go to the hospital and they get to stay with us. So this should be a review basically from block 1. So even if they look okay, there's the reports of the fever, they're under 2 months old, specifically under 1 month old, those ones no go. So under that 1 month old, review from block 1, but kind of delineating it out. I need to get fluid and a culture from all the places where there are fluid. So I need to get blood and a blood culture in 2 places. I need to get urine and a urine culture. I need to get CSF and a CSF culture. So any of those 3 places where they can have that serious bacterial infection, you need to get fluid and a culture from all of those places. Now, what is it that is not automatic? It's not automatic to get a chest x-ray. So that is not part of your automatic workup for a fever. That is going to be if there are respiratory symptoms. So if they have respiratory distress, if they have a cough, if there is something else that you need to add it to, then a chest x-ray. It's not part of your automatic workup. If there are GI concerns outside of the fever, they have diarrhea, they have blood in stool, they have something else, then you start adding stool cultures and stool studies. Not automatic. The only automatic things are places where there's fluid, where you get a sample of the fluid and a blood. Okay? Your empiric antibiotics. Highlight this one, star this one. IV, ampicillin, and gentamicin. So that should be, again, a review from walk 1, that's amp and gent. Acyclovir if they're concerned for HSV. Now you're over 1 month. So you're outside of that a little bit. You're still potentially under 2 months or 3 months. So this is the hardest stage, I think, just in general, because your risk stratification is they are maybe fine, but they maybe aren't fine. And you're like, that's not helpful at all. And you're like, welcome to pediatrics, where you're like, they're probably going to maybe be okay, but maybe not. And you're like, super helpful. Thank you. So the guidelines in my world, they will literally go down by days. So we have 1 to 7, 8 to 19, 19 to 28, 28. We go down to the day, all the way to day 90, right? So that's for me to worry about. You need to worry up to a month, up to 3 months, and then 3 and beyond. For those ones, so these ones, you do some of the fluids. So I need to, if it's in that, like, I don't know, I at least need blood and a blood culture, urine and a urine culture. And you will have to use your provider brain after that to say, do I need an LP? Do I need to get fluid off the spine and take a culture of that? So I work on the 3 strikes you're out rule. This is not in your textbook, this is just Dr. Klein. If I have 3 things that make me not feel warm and fuzzy about a patient, especially in this, I go ahead and do the LP. So if I'm thinking, that story was weird, there's something weird on physical exam, I don't know why their vitals aren't responding, something like that. If I have 3 things and I think about it more than once, I go ahead and do the LP. So everyone practices a little different though, so you will see some of that. Again, if respiratory signs, then a chest x-ray. If not, nothing automatic. If GI concerns, stool cultures, and nothing automatic. And this time, you are covering with just ceftriaxone or cefotaxime. You get that gram-negative coverage, you get the coverage for the encapsulated, and so you are good to go in that age range. When you get a little bit older, so now you're at that 3 and older, this is going to be one of the most common reasons that anyone's going to come in for care. You've gotten to know your child at that point. Fever is kind of common, but they're oftentimes, it's not as common. And so this is when you see them a lot. Most of the time it's viruses. That's why I say the pattern, is it following the hand pattern or not? Does it have any other abnormal things? Are they hydrated? All of those kind of things. And then beyond that, it's going to be based on your symptoms. So there's nothing going to be standard over the age of 3. It's always going to be, what does the patient look like in front of me? Where they're telling you those symptoms are. So for urinary symptoms, that makes sense. You're going to have a UA and a culture. For Peds, always put those together. There's not going to be a time where you're going to get a UA without a culture. For diarrhea or bloody diarrhea, particularly over 2 weeks, so if they've had diarrhea for 3 days, don't pick stool studies. It's pretty normal, we see that. So over 2 weeks. Again, respiratory symptoms can make sense that they get a chest x-ray for those. And then PCR. So when I was coming up in medical school, they were like, PCR testing, it's going to change everything that we do. Well, it didn't, right? It really didn't. So if I can tell the difference between a rhinovirus and an enterovirus, does that change my management at all?
No.
Not at all, right? It helps a little bit so that I can say, oh, all of these children have RSV, I'm going to put them on this side of the ward, and all of the ones with flu I'm going to put on that side, so they don't give each other another one. But beyond that, it really didn't change the management all that much. So careful with PCR. It can be really helpful if you need an answer. It is a diagnostic tool, but it's not an end all be all. One of the other things to see as you are going through, especially for pants prep, I think this is more helpful for the pants than in real life. Sometimes it can be helpful, right? About a month ago, what were we seeing? what virus that was everywhere?
Flu.
The flu, right? So if someone was like, I have the flu in January, you're like, yep, sure do. That would be weird if it was June. And you're like, the flu A positive? That's weird, right? So you will learn those patterns, but it's more helpful on the pants. Because if the pants says, it's the summer, they're trying to tell you that it's more likely going to be one of these. So your enteroviruses, particularly Coxsackie, is one of their favorites for that. They tell you it's a fall virus. It's going to be one of those cough, cold, flu viruses. Fall, particularly, they're usually telling you paraflu. So you'll get some of those. There's other than words, if I told you cruise ship, norovirus, correct. So there's going to be a lot of those things that we'll talk about throughout for pants prep. I think, again, it's more helpful for pants. So if they give you something like that in the question stem, or if I give you something, it's for a reason, to give you a clue. And it's good break time. So let's take 10, come back. An 18-month-old is probably not going to be strep. You're going to hear people that are like, well, my 2-year-old had, yes. Even if you look at the modified Centaur criteria, you don't get that point unless you're at that higher ages, just because it's so unlikely. So under the age of 3, don't ever pick strep. And then pneumonia. So we have a whole lecture on that as well when we get down to it. Your urinary tract infections, those are pretty high. So always remember that the highest number for their serious bacterial infections. You guys just had urology, so things to know about that. Who's going to get this? So the biggest one that I want you to look at is uncircumcised boys under 1 year old. That is going to be one of those specific risk factors in kids that you see. So typically under 1 year old, because they're more likely to have anatomical defects that we haven't caught. And then specifically males under 1 year who are uncircumcised. The fevers and UTIs are higher typically. So if you have a true bacterial UTI, you're more likely to have a fever that's over 39 degrees. So this is not those, oh, we just barely have a fever. Typically higher, because it's going to be concentrated in that one area. And then typically under 1 are the ones that we worry about for a true bacterial UTI because of those anatomic reasons. So we take that all as a whole. When we're looking at what do we do for those under 36 months, you get all of this in all of the other slides, but if you're trying to boil it down, do I know how to take this algorithm? We start at that top left. Are they under a month? They'll go straight to the hospital to get that full workup. Where do you need a culture from?
Blood.
The fluid. So what are those 3?
Urine.
Blood.
Lumbar puncture.
Urine. CSF. Yep. If they're over and they're 2 months old, you're still doing that for our purposes. If you're a little bit lower risk, so we'll say those 3 months olds, then where do you need 1 to 3 month old? Where do you need to get fluids from?
Urinary.
Urine and blood. Yep, and those cultures. And then eventually you're getting down to, are they sick or not sick? Do I need to hospitalize or not hospitalize? So this is just a recap. Bacteremia, when we talk about that, you guys just said it, it's from the blood. Just one of the things, words matter. Bacteremia does not mean the same thing as sepsis. Those are 2 different words, they have 2 different meanings. So sepsis is that you have a source that is causing your VQ mismatch, your ventilation and perfusion mismatch, right? Bacteremia just means I have bacteria in the blood. All that means. So if we're looking at that, bacteria in the blood. I have 2 types. I have it with a source and I have it without a hidden source. So if I have a source for this, I am looking at, I have gotten a sample and I know where it's from. So this would be the kid that you can hear a big pneumonia, you take a blood culture and it is positive. And you say, I know where that infection is. That's going to be a positive source for that bacteremia. Your hidden source is if you are doing a workup on the child, you got a blood culture, it's positive, but you don't know where that infection is. Is it in the lungs? Is it osteomyelitis? Is it an abscess in the liver? You have no idea where it's from. So it's going to be your occult source. And then the second half is really just because I got nerdy for a little bit, so you can cross that out. Just looking at what are you most likely to have. It's going to change over time with vaccines. So as vaccine prevalence decreases, we're going to start seeing some of these things come up again. and it got real nerdy about the different rates. So don't worry about that. It's really just looking at how many vaccines. I'm not going to ask you anything about this. I just thought it was interesting. Okay, how many days was fever of unknown origin for our purposes? 8. Correct. So it's been more than 8 days. We've done thorough history and physicals. We don't know what this is. We don't know where it is. What do we do next? Okay, so you guys already nailed it. So the duration is the only difference between our fever without a source and fever of unknown origin. So please make sure you know those definitions between which one. So I don't know what this is. I don't know where it is. What's just most likely based on epidemiology. So most of the time, we'll be able to find a source. It will make itself present. There are times where you start to think, is this JIA, juvenile idiopathic arthritis, or is this a leukemia that is presenting? So you start to put yourself in those different buckets. Is this inflammatory, neoplastic, or one of those rare symptoms? In adolescence, I start to think, is this more of an inflammatory bowel disease presentation? Is this some other autoimmune? Is this lupus presenting itself for the first time? Do they have risk factors for TB? Remember from block 1, we only ask questions up to the age of 6. So if you're an adolescent, this might be something to start screening for again. Any kind of the weird infectious. So they tell you, oh yeah, I actually spent all summer in Tanzania. I spent all summer in Argentina. I spent wherever, in the jungles of Timbuktu. Doesn't matter. That's when you start thinking, ooh, do I have one of these much more rare diseases? We won't spend a whole lot of time on those ones. And then oncologic. So most of these kids, there's something else going on. There was something weird on the CBC. There's some sort of weird bruising pattern. There's some sort of fatigue, pallor, something else going on. So we will talk about that at the end of this block. Same thing for your detailed history. Your history is going to make the difference. So I will give you those histories on your question stems here. Other things to think about just for that extended history, especially when you have a fever of unknown origin, as in we can't find what's going on. Is there any kind of weird dietary habit as well? So are they eating things that they shouldn't or necessarily be eating? So things that you always see in question stems, are they eating paint? Potentially that's going to be those lead levels. Are they eating dirt and they're significantly iron deficient? We see that a lot. We already said travel history. Any of the recent dental work, that one will pop up, especially for kids with congenital heart diseases. They will have had something going on, they got some dental work done, and now they have a potential endocarditis. So much more rare, but things that we look back on. And there is no standard shotgun set of labs for this. So we'll talk about some labs that you would get before you would call your specialist, but there's not going to be a shotgun set. It's going to be based on your history of what you would get. So that first off, we first have to decide, is my child sick or not sick? Okay? If they're sick and they're toxic, they are going to go to the hospital. Okay? So I first have to decide, is this an inpatient or an outpatient workup? The second part is to determine which labs you need before you call the specialist. So before you call before you call any ID specialist, this is what you should at least have when you are calling them to consult them. You need a CBC. You need a baseline CBC and a blood culture. I would recommend that you have 2, that you've trended it. So not necessarily part of the workup. What I have seen, every single ID specialist has asked me to get another one. So I say go ahead and have 2, so you have trended them. The urine with the urine culture, always paired together. Your inflammatory factors. So what is my ESR, CRP? Some newer places or newer availability for procalcitonin is going to be helpful. Did I test for any TB or at least screen for that with some questions? Did I get any PCR testing? Did I get a rapid flu? Did I get an RSV? Did I get a COVID test to at least rule some of those things out? Did I get a panel? And then have I done any other standard imaging? Most of the time, they will at least want a chest x-ray. Have you gotten a chest x-ray? So if you call infectious disease without these things, they will probably hang up the phone and tell you to try again. If you have all of this, and you've looked at it, you've trended it, you've done multiple exams on this child, and you still don't know, that's the perfect consult for them. You've gone as far as you can with that fever of unknown origin. And really, if you have nothing else to do and you don't want to study derm for this week, but you would really like to study zebra cases of pediatric infectious disease, it's something to think about. So I was just talking over the break about what does the pediatric specialty have that you guys don't get. So this would be one area that they do a whole lot more on pediatric infectious disease. So some of those rare zebra type things. So that would be one area as you're studying on your own after PA school is over and continuing your own education. Hot topic of Peds infectious disease. Okay, what is it? Just make sure we're all on the same page. What is the definition of a fever? What's that line? 38 degrees centigrade, and we translate that into Fahrenheit. That is 100.4. So if I give you 100, that's not a fever. Perfect. What are our three categories of fever? With a source, fever without a source, unknown origin. Yep. And then what day is that? One more time? 8 days. Okay, that takes all of fever. So there's this like really kind of awkward transition because there's not a great place for this as well. So we kind of move over into meningitis and encephalitis because a lot of times the only common thing that we're going to see that's consistent with kids, specifically with those two, are going to be the presentation of fever. So our next lecture later on in this week is infectious disease, so it's kind of a nice in-betweener. Okay, why do we care so much and why do we put it in here? Number one, it's an in-betweener. But number two, it has a lot of morbidity and mortality associated with this, particularly for kids. And so this one's a no miss, even though it has a lot of vague signs and symptoms. So it gets its own little nod to this in this lecture. One of the things that I don't think that we do particularly well in medicine is use our words. So when we're thinking about things, we'll just say signs and symptoms. And really, it should be the other way around. It should be symptoms and signs, because that goes with SOAP, like your SOAP note. So a symptom is going to be something that the patient is telling you. You can't prove it or not prove it. A headache is a symptom, right? A sign is an objective finding that will go in your O portion of your SOAP note. It is objective. It can be measured. So a fever is going to fit into your signs. So instead of saying signs and symptoms, we really should say symptoms and signs to go with your subjective and objective. But that's just me. So, but making sure that you can classify, is this a symptom, something that the patient is telling you that you can't prove, like a nauseous headache, those type of things? Or is this a true sign that you can elicit on a physical exam? The different Kernig's and Brzezinski's signs, a fever, something that can be induced like that, nystagmus, a seizure, those type of things. And remember our definitions, so the meninges, it's involving the coverings around the brain versus the encephalitis that is going to be the actual brain parenchyma itself. So just a reminder of those basic anatomies. The vaccines have changed this a lot, so it is certainly a decrease in the morbidity and mortality, but something we see often. And HSV is still going to be that pretty devastating one in those babies. We'll talk some of that. So meningitis. When we're looking at those inflammation of the meninges, big risk factor is if you've never seen this before, this one your body cannot handle, often because it is an encapsulated bacteria. So on your test questions for the PANTS, because it is so bad, if you've never seen it, it's hard to build an immunity to it. And the first exposure to it, highly transmissible and highly deadly. When you are given something in a question stem that says college dormitories, barracks, cruise ships, anything where people are going to be living in close quarters, they're trying to tell you that it's highly transmissible like this. So the way I've seen it on every PANTS question was either military barracks or college dormitories, because it's the right age with your adolescent population and it is close living spaces. So if you see those two, should highlight that for you. If you see complement defects, so way back, I believe Major Holzberg has a whole thing on complement and those cascades for those inflammatory pathways. If you have a genetic disorder in one of those pathways with your complement series, you are not going to be able to mount a defense against Neisseria particularly. So you are specifically susceptible to Neisseria meningitis. And then splenic dysfunction. So what's the issue with spleen? What kind of bacteria does the spleen pull out?
Blood-based? Like a filter for your blood.
It is. It's a filter. What does it filter out? Which type of bacteria? Particularly.
Encapsulated?
Encapsulated. There you go. What are those type again?
Neisseria?
Neisseria. Streptococcus. Strep pneumo. Klebsiella. Haemophilus influenza B. Your Haemophilus influenza. Those 4. I'm probably going to ask you those like 100 times. Because anytime you see splenic dysfunction, you should think encapsulated bacteria, they're going to be a risk for meningitis. I got to vaccinate against what I can. I got to prophylax against those encapsulated bacteria. So, strep pneumo. Oh yes, we just discovered this was an encapsulated bacteria. ID will be so proud. Okay? When I was in medical school, they said, hey, we have come out with an increased pneumococcal vaccine. It is pneumococcal 7. How many species of pneumococcal do you think that covered for?
7.
7, exactly. So we had 7 strains of pneumococcal covered. Then I got to residency and they said, new vaccine, we have pneumococcal 13. How many strains of those?
13.
13, yes. What we're at now that we standardly use is PCV 20. So in most of your MTF clinics, you'll go out, it will be PCV 20 covering those. There is a PSV 20 or PPSV 23 with some additional strands. When you get out, you will have the ability to order specific vaccines to help cover specifically if people have things like asthma, they have splenic removal, they have sickle cell, things like that, where this additional coverage will help them. Neisseria, again, we have a vaccine for that one. It's another encapsulated. We see those in the colder months, winter, spring, and this one, again, a lot of times if you are in those tight spaces. So things about that, are you in a tight living space, complement deficiency, in those age groups, kind of those bimodal, young daycare, and then adolescents, and then unvaccinated. You see those. Haemophilus influenza B. We cover that now, so it's kind of an interesting, there's a lot of Haemophilus influenzae, and the type B has a particular types of capsule around it that makes it pretty resistant. So it's not all Haemophilus influenzae, all of them are encapsulated, but the type B particularly is the type that will cause serious infections. That's what we vaccinate against. That one, in a question stem, it's probably the most common thing you'll see with daycare. So if you get an unvaccinated and a daycare in a question stem, they're almost always asking about HIP. So all of those are the most common bacterial things of those no misses for meningitis. So what is this going to look like? So this can present in several different ways, shapes, and forms. So sometimes this will be very, very sudden onset. You see all the commercials where it happened very fast. That can happen and does happen, particularly with Neisseria. So that's going to be the one that you see it happens so fast. The other ones that you will sometimes see is kind of this insidious, couple of days of fever, had some sort of preceding prodrome or preceding symptoms, kind of non-specific, and it starts to get specific as the days go on. So they get sicker, it doesn't follow that pattern where you would expect them to get better. That's going to be most often. So that kind of that insidious takes a couple of days to start presenting itself compared to the more dramatic one. The vital signs, typically you would expect that you are going to see the fever and tachycardia. I wouldn't expect to see hypotension unless a child is very, very sick. I would expect to see hypertension. Hypotension tells me that they are septic and they are starting to get very, very sick and you need to intervene very, very quickly. That rash of Neisseria, star, highlight, underline that one. Make sure you are familiar with that. If that specifically goes with Neisseria, the Neisseria is specifically an encapsulated bacteria. And so specifically need to have something on board empirically to make sure that you are covering for that. Again, petechiae or coalesced into purpura, a sick child with fever, specifically unvaccinated, we're going to treat with, what was our antibiotic? Gent, if they're under a month, older than that, ceftriaxone, good, or cefotaxime, good. Coalesced into purpura. Things that you will see typically in older kids. So we will always look for that nuchal rigidity. So can they move their neck or will they not move their neck? So most of the time, kids, like when you see them fling themselves around and fling their heads back, if a child who is a young child will not move their neck, that is very rare. Children should never be looking like I don't want to move, right? Nuchal rigidity, not normal in a kid. If I'm looking at back pain is dime a dozen amongst adults. If you find an adult who doesn't have back pain at some point, they're lying or something, right? Gravity comes for us all. But if you have an 8-year-old with back pain, that's not normal, right? So a kid that's telling you back pain, if you see back pain as a symptom in one of my tests, that ain't normal. It's normal for your other classes. It's not normal for peds. Okay? If you see the Koenig sign or Brzezinski sign, typically it's going to be in an older kid. You are around babies or little kids, they're super, super flexible. They're like little Gumbies, right? They're like, their legs are behind their heads and they're just all over the place. So not a super specific sign until these kids are a little bit older. So not super helpful. So we'll go over those signs again. The symptoms. The signs. There we go. The other things that you're going to see, if they are younger and they have that anterior fontanelle bulging, bad sign. They are having emesis over and over. Anything where it's going to say that there's an increased pressure around the brain. Any vital sign changes. Decorticate or decerebate. Do you remember the difference between those? Decerebate, decorticate. Correct. And then coma, obviously if we are down into coma, seizures, those type of things, it's gotten significantly worse. So we're looking at that. We have the nuchal rigidity where they don't want to move or you can't get their head forward. Remember a positive Brzezinski sign, if you move the head forward, the knees come up with it. If you go to straighten a leg of a child and bring it up, that would be positive. Normally kids' legs just move very, very easily. If that is hurting when you are trying to move a leg or move their neck, not normal. That is something that is not right. So very specific sign, but really once they're in that 2+ age range. Bulging fontanelle. So one of the times we had a patient where I was really worried about a bulging fontanelle, and I think I was an intern at the time, and I was like, oh, this child has a bulging fontanelle, and I was so worried about that. And I had a senior resident come in and say, the child was crying, and she said, is it really bulging? Or let's have gravity help us. So she just set the baby up, and the fontanelle was like, whoop, it was totally fine. Right? So sometimes use your physiology, use gravity to help really look at this. So this is a good example of a bulging fontanelle that you can see at the top in between those sutures. Would that change if we sat the baby up? If that doesn't change, then you should pucker. Right? That's telling you there's true bulging, there's true pressure, that no positional change is going to matter. You sit the baby up and it goes away, or when they stop crying it goes away, not as concerned. So that bulging fontanelle, big deal. Our LPs. So I want to get that lumbar puncture, especially if they're under that month. That's going to help me say what is going on, bacterial, viral, what do we have here? Things where I wouldn't do this. So, a couple of things. If they're coding, and I've seen residents do this. So the child is coding, severe cardiopulmonary compromise, and someone's in there like, I got to get an LP. Not the time. Code the child first. Figure out the diagnostics later. Go ahead and start the antibiotics. So severe cardiopulmonary compromise, don't do that. If there is a gigantic infection or something that you're concerned right at the side of LP, you're not going to do an LP at that site as well. And then finally, if there's increased ICP, so that's the biggest one. What happens if you have increased ICP and you put a needle there? what happens? Physics will tell you what will happen there.
Guys are
Right, the pressure changes and then what happens? You just introduce lower pressure there. What happens? What happens to the brainstem? Brainstem herniates through the foramen magnum. Right? So make sure that you do not have elevated ICP before you do this. So CT scan or not recommended. That is a CT scan for all. So radiation is not going to be there. So if you had a focal, if you had a shunt placement, you have something else that makes you say, I really need to do an LP or a CT scan before, but it's not recommended or routine that you go ahead and get a CT scan for everybody. Don't do that before you LP. And if there's going to be a significant delay, just go ahead and start antibiotics. We will figure out the LP later, right? Why do we really need to see what it is if it's in the spinous fluid or not? What does that determine?
the cultures.
The cultures, yep, so it's going to help determine the culture.
Biogram.
And the antibiogram. Why does that matter specifically for meningitis? Do you think we treat longer or shorter for meningitis? Longer. Yep. So you treat, as opposed to 14 days for bacteremia, you're treating 21 days. You're determining, do I need to send this child home with a PICC line? Do I need home health? How long do we keep them in the hospital? So having the diagnostic clarity helps with your timing and your dosing of antibiotics. But we can figure that out on the back end. It's more important to save their life and save the morbidity mortality. That's to this point. If you can get a culture, that's great. Most of the time, once you start antibiotics, those gram stains will clear just a couple of hours later. Then you have a partially treated one, and that is why there is a whole specialty of infectious disease to help you sort that out. So save the child first, we'll figure it out on the back end. If you can get a sample, great. A traumatic tap, you guys will hear that when you go to phase 2, potentially in the ER. So a traumatic tap means they did the lumbar puncture, and there's some sort of vessel that they hit, so they got spinous fluid, and there's blood in there as well. The lab can also figure that out, and you can interpret those with a bloody tap. Still able to get a culture and a gram stain, so a bloody tap or a traumatic tap, that is okay. You can still get that. I'm not going to ask you how to read this. So this is more of a phase 2 thing, but what I want you to be aware of and thinking in general, if I have a sample of spinous fluid and I have more cells in the spinous fluid, so thinking of like a bacterial, will my pressure be higher or lower?
Higher.
Higher pressures, yep. Will I have more cells or less cells?
More cells.
More. Will I have more glucose or less glucose?
Less glucose.
Less glucose. It's not quite physiologically accurate, but I'm always like, oh, the bacteria are going to eat the glucose. Will I have more protein or less protein?
More.
More, yeah. So that's literally it. You just read a or you just read a CSF studies. Like that's all that's doing. So when you get to phase 2, we'll talk specifically numbers. Again, I'm not going to ask you specific numbers about this, but just kind of general concepts about that. What is my differential? So am I able at that moment to determine if it's the meninges or if it's the parenchyma? No. So encephalitis is always going to be on the differential for meningitis. Is it a seizure or is this meningitis? That's always one of the things. And then how am I determining this? Well, usually the focal symptoms can help with that. Seizures will be more likely that it's encephalitis because the parenchyma itself is involved as opposed to the outside irritant structures there. If I have focal neurologic findings, I'm more concerned that it's not something in general going on all the way around the brain or a brain parenchyma itself. I'm more worried that there's something focal. So if I think that if I see focal findings, I certainly would want to get a scan for that because that's not normal and it's probably telling you that there's something in one spot as opposed to something globally. Is this a partially treated meningitis? So this would be one of those reasons. If you don't have a source, do not just throw antibiotics at it. If you're like, I don't really know what this fever is, but these parents are real mad, so I'm just going to give a little amoxicillin, and now it's a couple days later, and they come in, is this a partially treated meningitis? Don't know. Don't throw that. Not just meningitis, sometimes antibiotics and steroids, we'll talk about that later, can inactivate protocols that we use for HEMONC. So if we've started that, you're not eligible for some of these things anymore. So for the love of God, if you don't know what you're treating, don't just throw antibiotics to your kid. Okay, so your treatment is going to be a couple of things. So we said we knew what we were going to do for those encapsulated those encapsulated species, so ceftriaxone, and then staph was up there as well, and then our gram-positive coverage, we're adding vancomycin. So if you think that this is meningitis, if you truly are like, this is meningitis, I am empirically covering specifically for that, vancomycin, ceftriaxone would be your go-to for that. The meningitic dose, so it's a higher dose. I'm not going to ask you about the dose, but just in general, to be aware of that. And because that has to get across the blood-brain barrier, so that's why it's a meningitic dose. If they can't have penicillins or they have a severe cephalosporin allergy, your next in line would be meropenem. That would be your go-to for that. You don't need to repeat an LP. So it is one of those that when they get clinically better, you are good to never repeat the LP unless neuro or ID or somebody wants you to. It's not a standard part of that practice. We already said a longer time for this IV treatment. So a lot of times these kids get sent home with a peripheral indwelling central catheter or a PICC line, and they finish out their antibiotics there. Complications of meningitis. So this is right around the brain. So the complications are often if they truly have a bacterial meningitis, and they are not for the faint of heart. So we might have saved the child and saved their life, but they often have sequelae associated with that. So it goes after some of these parts of the brain. So this should make some sense. So SIADH, what does that stand for?
Appropriate antidiuretic hormone.
Yep. Too much or too little ADH?
Too much.
Too much. So what's happening with their fluid with that?
Retention.
Retention, correct. So too much retention of fluids. You have hearing loss as well. What cranial nerve is responsible for hearing? 8. Yep. So that 8th cranial nerve is highly susceptible to this. Effusions, you can see a recurrence of this. So a lot of children that have a true bacterial meningitis will end up with some sort of pituitary issue, some sort of a blindness, deafness, seizure, learning disorder. There's some sort of sequelae of that. So a significant portion, even if we save them, will have some sort of sequelae. So this would be one. If you even think meningitis, go ahead and empirically treat. We can always back off. It's hard to do it after the fact. Poor prognosis. This should make sense. The younger you are, the worse that this outcome is going to be. This should make sense from block 1. Everything goes worse when you were preterm or a young baby. So under a year, particularly, but they don't do as well. So young age is bad. Long duration before they got antibiotics, that should make sense as well. If they were sicker at presentation, so by the time they get to the ER or to definitive care, if they're already having seizures, comas, shock, anything like that, typically are going to have a worse outcome. And certainly immunocompromised, but this one is always one that I had to think about. So if you do a gram stain or a culture and you don't have white blood cells, that should be really concerning. They're not having an appropriate immune response. And that's going to tell you something isn't right in the way that this child is responding. So that's a worse prognostic indicator. I think we actually can finish this one today. Encephalitis then, this is the actual brain parenchyma. Right? So more or less likely to see seizure activity. More, correct. I'm just saying words now. So now this is brain parenchyma itself. It can be diffused, it can be localized, which is what makes encephalitis hard. Because if it's localized, it can often look focal in nature. If it's diffused, it's going to look obviously more global in nature. Can be acute, have some of those exact same presenting symptoms. So this can be hard to tease out, which is where the LP can often help you with that. What I want you to think about, at least for purposes of pediatrics, is that meningitis, although viral meningitis is the most common type, we do see those bacterial types. I'm seeing encephalitis. or the ghost of the senior room that's coming in here. Thinking viral in nature. So a viral encephalitis is going to be your most common type that we are seeing. Herpes again should be the first one that you're thinking. Again, what are you treating herpes with?
Acyclovir.
How are you treating? Topical, oral, IV? IV. Yep, IV acyclovir all the time. Less common, but we are seeing it rise, is going to be measles. Things like the Japanese encephalitis. You can see an influenza type of this. And if there's a history of a dog bite, always in the back of my mind, I was like, is this a rabies encephalitis? Remember the characteristic finding of rabies? What are they afraid of?
Water.
Yep, so the West Nile is your most common one that we will see, so just epidemiologically. Can be transmitted several different ways, pretty non-specific, still fairly rare. You're seeing even in how I'm talking about this one, probably not super high yields for a test question since it's really hard to distinguish between something. Same in real life with that too. These viruses for this type 1 and type 2, a good question that was asked earlier. What are we seeing in that? In general, for our purposes, I'm not going to distinguish between type 1 and type 2. You are going to treat them both with IV acyclovir. Both can have devastating outcomes. There's really that epidemiologic risk and the progression that changes, and that's really a little bit beyond the scope for this. If there is a history in mom's history or some sort of sexually transmitted disease history in the child themselves, something to consider. And then in our next one, we'll talk about varicella zoster. So a rare complication of the chickenpox is going to be an encephalitis. So a lot of times people will think, oh, this is just an itchy rash that we try to prevent from kids. Well, yes, for most, but some can progress to a varicella encephalitis. So we'll talk about all the different things that varicella can cause. Variable presentation depending on what part of the brain parenchyma, and again, if it's focal or diffuse. So it can have that several days of non-specific, can be then a little bit more specific if it is focal. Seizures are more common. You guys already nailed that one a couple of different times. And then depending on what type, you can have some serious complications depending on what type and where in the brain. So if it is more of your anterior horn, if it is more of the periphery, it's going to vary in what it presents like and what its sequelae is like. So things to be aware of. This is where you would really want your serologic testing in your PCR. I believe over at SAMC it's called the BioFire test. So it'll give you a whole bunch of different things from a CSF sample to see what is in there and what is not. The one to be aware of is mycoplasma, or what was interesting about that bacteria. It's an intracellular bacteria. It lives inside another one. So something that is specific about that one. It's also why it will often show up on your viral panels. You can use your PCR testing, some viral testing. A lot of these are reportable, so if you get something positive back for West Nile, that's certainly one that's reportable to infectious disease, to public health, to a bunch of different places. Most of the time, there's not a specific treatment. There are times, HSV being the example, that if you haven't gotten by now that I'm hitting that one pretty hard. So please be aware of that one. Most of the time, it's supportive care. So we have to let their brain be supported in time for their body to react appropriately. So if they have seizures, they need to be managed. They're having cardiopulmonary compromise into the ICU. They're having increased intracranial pressure. How do we help with that? And making sure they are still perfusing. So things to think about most of the time in encephalitis where there's altered mental status, they are going to an ICU of some sort, so making sure that they don't acutely decompensate. A lot of these kids will need rehab services on the back end. So their brain has been infected, their brain has been severely compromised, and so these are those kids that are probably going to need speech therapy, occupational therapy, physical therapy on the back end to make sure they have appropriate rehab. Thinking, do they need another hearing test, even if they were outside those typical hearing screen ranges? Do they need neuro on board? They continue to have seizures. There's a lot of sequelae that happens after this. Prognosis depends on certainly what was causing it, how long, and how severe it was. So that should make sense. So as with anything, any pathology at this point, if it's worse, you're going to have a worse outcome going most point. Prevention, vaccinate against who you can. So make sure pets, if you have any say to that, oh, family just got a new puppy, make sure that they are vaccinated against things like rabies. You can vaccinate against something like Japanese encephalitis if you're going overseas, certainly doing that. Precautions for things that are mosquito in nature, so long sleeves, DEET is going to be helpful. Otherwise, prevention is the key for encephalitis. Okay, a couple of questions here. 4-year-old presents with 3 days of fever, increased irritability, what are you already thinking? Meningitis, and worsening fatigue. Vitals are notable for a temperature of 102.5. Do we have a fever? Yes, we do. Heart rate of 145, respiratory rate of 35, normal blood pressure. A little bit high there. On exam, he appears tired and pale with palpable purpura on his lower extremities. What is that?
Neisseria.
Neisseria meningitis. Yep, Koenig sign is positive. LP is pending. What do you do?
Give antibiotics.
Which one? C. Okay, yep. Why don't you do A? What's going to happen if you just wait longer?
It dies.
What are some of those sequelae? Seizures, hearing, SIADH, death, right? Yep. Send patient for a CT scan. Why would we do that? No, we wouldn't. What if we hadn't gotten an LP yet? When do I do a CT scan?
If they're stable and you're concerned about
ICP or focal findings. Yep. Stat referral to neurology. Why is that one wrong? What is neurology going to tell you to do? Give the antibiotics and then hang up the phone and call you an idiot. Well, discharge with closed PCM follow-up. When would you want to do that?
When it wasn't any of these.
Yeah, if you are really wanting to just tank your career and throw your license away, pick E. Okay? Otherwise, okay. So please be aware of meningitis more than encephalitis. That one's probably a little bit more common. Can you define a fever of unknown origin? The things that I tried to say over and over and over, those are the ones to highlight. Questions, comments, concerns, anxiety?